Hello everyone. When you first get infected with the varicella zoster virus, you get varicella, aka chickenpox. While the acute symptoms of chickenpox usually subside very quickly, the virus never really goes away, and its genetic material persists in sensory ganglia and for decades. Usually, this latent infection produces absolutely no symptoms. But as the person gets older and their immune system gets weaker, especially specific immunity against varicella zoster, the virus gets the opportunity to reactivate, only this time, it doesn't cause varicella. It causes shingles or herpes zoster. So, the name of the virus tells you what it can cause. First infection, varicella. Reactivation, herpes zoster or shingles. Your typical patient will be a person in their 70s or 80s who will present with intense, acute, unilateral pain somewhere in the trunk and the chest or in the abdomen. After a few days, this typical herpetic rash will appear in the same place where the pain started. Now, since the virus reactivates in the sensory ganglion and travels along the affected nerve, the rash can appear anywhere, from the spine down to the median line. If it crosses the median line, it's unlikely that this is herpes because if the nerve cannot cross it, the rash cannot cross it either. So, this rash will typically affect one dermatomy, maybe two neighboring dermatomes. The rash is very characteristic, so usually, you won't need any kind of diagnostic tools. Reactivation, herpes zoster or shingles. In the rare cases when you are not sure, you can take the scrapings of these blisters and send them for PCR for varicella zoster virus. Of course, if PCR is available. But again, most of the time, you will know that this is herpes zoster. And you will simply start treatment. Usually, you will use either acyclovir or valacyclovir. These are antivirals directed against herpes viruses, and basically, either one should be adequate. These are antivirals directed against herpes viruses, and basically, either one should be adequate. Valacyclovir is a little bit more convenient because the patient has to take it 3 times a day instead of 5 times a day, and the duration of treatment should be 7 days. As a general rule, we should start the treatment within 72 hours after the first appearance of the rash, but if you see that there are still new vesicles forming, well, we can start treatment even later than that, after 4 or 5 days. Beyond that, antiviral treatment probably won't make much difference. In short, this is your typical garden variety intercostal herpes zoster that you will see a million times. Now, let's turn our attention to the things that should alert us to the possibility that the treatment might not go as planned. These are antivirals directed against herpes viruses, and basically, either one should be adequate. Remember how the varicella zoster virus reactivates when your patient's immune system gets weakened, usually by old age? This is why shingles are uncommon in people younger than 50. Most patients are in their 70s or 80s. So, when you do see a young person with shingles, you should ask yourself, why would this happen to this patient? Are they immunocompromised, perhaps? So, ask them, are they on any kind of immunosuppressants? Do they take corticosteroids for some autoimmune disease, or are they organ transplant recipients? Anything. Many times you will find nothing, but you still have to ask. There is one cause of immunodeficiency that you should never miss, and this is, of course, HIV. Bottom line, if you have a young person with shingles, you should recommend testing for HIV, but not only that. In truly immunocompromised patients with shingles, this seemingly localized infection can quickly become systemic, so make sure that you examine the entire surface of the skin, looking for signs of generalized zoster. This will look kind of like a mix of chickenpox and herpes zoster because you will see these red patches and blisters everywhere. They will spread beyond these 1 or 2 dermatomes are usually affected. If you have a patient with generalized zoster who needs to be hospitalized and needs to be treated with intravenous antivirals, please don't forget that. Because not only the skin is affected. Many times, the liver, the lungs, the brain, and all sorts of organs can be affected. This is a life-threatening condition in an immunocompromised patient, but not only that. In immunocompromised patients, this rash can look atypical. It can look more severe than your normal zoster with a hemorrhagic or necrotic area. So, be careful with immunocompromised patients, even if their rash doesn't appear to be very impressive in the beginning. Of course, if they present after 4, 5, 6, or 10 days of illness, you should still start antiviral treatment because many immunocompromised individuals simply cannot control this infection. Okay, sign number 2, fever and systemic symptoms. Fever with rigors and chills are unusual in patients with your typical uncomplicated intercostal zoster, so if your patient does have a fever, especially if it appeared after the onset of the rash, you should suspect a complication. First, look for signs of cellulitis. These painful blisters, people often scratch them and touch them. This is the perfect opportunity for bacteria like streptococci and staphylococci to enter the skin and cause cellulitis. Of course, it's not always easy to discern whether there is a bacterial superinfection because the skin is red, to begin with, and these blisters can often be yellowish. This can look like pus. Nevertheless, you should take a close look, and if you suspect cellulitis, of course, you will start antibiotics. Generally, if your patient with shingles has a fever and they look unwell, again, you will look for signs of systemic illness, meaning generalized zoster. Next, the location of the rash also matters. While intercostal zoster is by far the most common. If you see a herpetiform rash on your patient's forehead and the area around the eye, this is ophthalmic zoster. This is significant because this virus can affect pretty much every structure of the eye, and it can result in a permanent loss of vision if not treated properly. So, if you do suspect ophthalmic zoster, it's a good idea to consult an ophthalmologist. They will be able to better assess the degree of involvement of the affected eye, and they will prescribe topical treatments like topical corticosteroids in addition to systemic antivirals. In mild cases, you can use oral antivirals, but personally, my colleagues and I prefer to use intravenous antivirals whenever we deal with ophthalmic zoster, especially if there is any kind of pain in the affected eye and if there is any kind of vision impairment. And finally, pain. Many patients continue to experience pain for weeks, sometimes even months, even with timely treatment, and they often ask us whether this means that they need more antivirals. The answer is no. Viral replication is done. Inflammation is done, but the damage done to the nerve persists, and it will take time to recover. So, these patients will need all sorts of painkillers. Some of them will need to see a specialist for pain management, but what they don't need is additional antiviral therapy. Thanks for watching.